Hello everyone and welcome to another video on chapter 38 where we're talking about the alterations of the digestive function. And we're going to start off with gastritis, then we'll discuss peptic ulcer disease and move into malabsorption syndromes, excuse me. All right, so back to gastritis. This is when we're going to have inflammation within the gastric mucosa, and we'll separate this into acute gastritis and chronic gastritis. And some common causes are going to be taking NSAIDs, H. pylori infection, and physiological stress. Now let's focus on acute gastritis. We are going to injure that protective mucosal barrier that would be lining the inner portion of the stomach. And we have NSAIDs that will inhibit the prostaglandin synthesis, which will stop or impede the mucus secretion. Another common cause is when we have an H. pylori infection, and that causes inflammation, leading to increases in gastric secretion in the antrum region, but we also see decreased gastric secretions in the fundus. Now, this type of gastritis is going to be more of local irritants, creating injury to the mucosa. And so, like we said, it could be taking NSAIDs, an H. pylori infection, it could be taking aspirin or an oral steroid, drinking too much caffeine or eating spicy food, drinking too much alcohol. That could all cause this to come about. Now, as we shift into chronic gastritis, we're going to see that there's an absence of grossly visible erosions. It's almost as if it's going a little bit deeper and will potentially change the type of epithelium we have within this mucosa. So we tend to see the chronic gastritis in older adults, and we have some different types. So when we have chronic fungal gastritis, also known as type A or an immune type, it is going to be more of a multi-genetic disease. And it's very rare. It is a recessive genetic disease where we tend to lose the T cell tolerance and develop autoantibodies of the parietal cells. And we know that the parietal cells are going to secrete hydrochloric acid and also intrinsic factor. So we're going to start to see a reduction in hydrochloric acid and the intrinsic factor. That mainly is going to affect the body and the fundus of the stomach and can lead to mucosal atrophy. Well, also because we don't have that intrinsic factor to absorb vitamin B12, may see our B12 anemia take place, also known as pernicious anemia. And without our hydrochloric acid being present, it's going to start to cause a disruption within that feedback mechanism and will cause our gastrin to be secreted, which in turn will cause gastric secretion. Now, shifting gears into chronic antral gastritis, this is known as type B or the non-immune type. We see this more commonly. The chronic fungal gastritis, we see that in about 10% of the population, whereas the chronic antral gastritis we'll see a lot more. We really see it only take place in this antrum region, and we'll see high levels of hydrochloric acid. This tends to be caused more with taking NSAIDs, drinking lots of alcohol, smoking, or an H. pylori infection. And we can have the inflammation move up to the fundal region, and we can call this type AB because it's causing inflammation all over, really. And therefore, we can call it pangastritis. Now, there's also a type C, and this is known as chemical gastropathy. And we don't see it pictured here, but we do know that we have the bile and the pancreatic juices coming into the duodenum here. So what happens in chemical gastropathy or type C gastritis is we're going to have a reflux, a chronic reflux of those juices into the stomach. And we tend to see this happen in cases where there's been some type of surgery that took place to connect the stomach to the duodenum or the jejunum. Those would be called a gastroduodenostomy and a gastrojejunostomy. But all in all, these types of chronic gastritis is going to cause inflammation, mucosal atrophy, and epithelial metaplasia. And these changes could become dysplastic and eventually transform into carcinoma. So the symptoms may be vague, but it can include anorexia, fullness, nausea, vomiting, epigastric pain, or gastric bleeding. And for treatment, we can try and be as conservative as possible by eating smaller meals, eating a soft, bland diet, and avoiding alcohol and aspirin or NSAIDs. If we do have a H. pylori infection, we want to take antibiotics, and if we have anemia, we could take supplemental vitamin B12 to try and get that to absorb. Now let's shift gears into peptic ulcer disease. This is when we're going to have a break or ulceration in the protective mucosal lining. So this is an illustration showing you the different layers of the GI tract. We have within the lumen that makes the closest contact is the mucosa. Then we have the muscularis mucosa, which is a part of the mucosa. Our submucosa is our second layer. We have our tunica muscularis, also known as muscularis externa, and then we have the serosa is our fourth layer. So what we start to see is more of a bit of an erosion within the mucosa, our first layer, and this tends to take place in the stomach or the proximal duodenum, sometimes within the esophagus, and we know within this area we have a lot of mucosal protective factors, but they're overcome by erosive factors that would include NSAIDs or H. pylori. And we can classify these erosions into acute or chronic ulcers. When we have a true ulcer, that's going to extend through, so you can see this pictured over here, it's going to extend through the muscularis mucosa layer, and it can move further down and start to damage the blood vessels, which can cause hemorrhage to take place, but rarely is it going to continue to perforate into all of the layers and open up into the peritoneal cavity. When we describe a superficial erosion, that means that we have eroded through the mucosa, but we haven't truly gone through the muscularis external layer. But if we have a deep one, that means that we've gotten through that third layer. And some of the clinical manifestations that we would see in this are burning, more of a cramp-like pain when the stomach is empty, and we find that near the xiphoid process, the end of that sternum, where that pain could be felt. And we do see relief by eating food or taking antacids. Now we can have some complications. We could get some GI bleeding, again, by damaging the blood vessels within these layers. We can also develop an obstruction within, let's say, the end of the stomach near the pyloric region or in the duodenum, and rarely perforation to take place. In rare cases, someone can have Zollinger-Ellison syndrome, and this is when we have a neuroendocrine tumor or multiple tumors of the pancreas or the duodenum that is going to cause an increased secretion of gastrin that will then cause the stomach to have excessive secretion of gastric acid, and that develops the gastric or duodenal ulcers. We can also develop gastroesophageal reflux with abdominal pain and diarrhea. Now let's talk a little bit more about duodenal ulcers. This will be the most common type of peptic ulcer, and here we can see an illustration of a deep ulceration taking place in the duodenum. You could see that we went through the mucosal layer, submucosal layer, and we are down in the muscularis external layer. And we have this crater develop here through the use of NSAIDs. You can see the placement of this ulcer. So here's the end of the stomach, the pyloric sphincter is here, and then this would be the superior part or the first part of the duodenum where it developed. And this is what it can look like in actuality. So we've kind of talked about these as being developmental factors within this type of ulcer, but essentially it's because we've got high amount of acid and pepsin concentrations within the duodenum. We're going to see increased levels of gastrin that result in increased stomach acid secretion and an increased acid load in the duodenum. And so this starts to promote metaplasia of that epithelial tissue in the duodenum, and that favors H. pylori colonization. And because we know we have an infection, our immune cells become activated, and we call upon our B and T cells and our neutrophils, which are going to secrete cytokines and cause damage to the mucosa. So we see it characterized by intermittent pain in the epigastric area. It can be relieved by eating or antacids like we saw before in the previous slide, and we can have some complications here again, GI bleeding, obstruction, and perforation. And we tend to see that the pain that develops begins within 2 to 3 hours after eating. So within that time, the stomach is becoming more empty. So to manage this, we want to relieve any causes and effects that can cause hyperacidity and prevent those complications from taking place. Let's focus on gastric ulcers now. This is going to be less common than duodenal ulcers, and they tend to develop in the antral region of the stomach, near that area where we have our acid-secreting mucosa of the body. So let's look at this figure over here from your book. We see the causes of the ulcer. It damages the mucosal barrier, and we get a decrease in the function of the mucosal cells, the quality of the mucus that's going to protect the mucosal lining, and we also lose the tight junctions between the cells. So now those acidic components or the bacteria can get in between the cells and further damage the mucosa. So let's start off over here on the right-hand side. We get formation and liberation of histamine, and this is going to stimulate an increase in the acid production and pepsinogen production, which we'll talk about over here, and affect our blood flow. We can see that we've got local vasodilation taking place, and we'll also get increase in capillary permeability. That can cause a loss of our plasma proteins. We get mucosal edema and loss of plasma into the gastric lumen. So let's revisit that conversion of pepsinogen to pepsin. We know that we need an increase in hydrochloric acid to do this, so that histamine, by increasing the acid, causes that to take place, and then we get further erosion of that mucosa and destroy the blood vessels, causing bleeding and the ulceration to develop. Now, if we have a H. pylori infection, that is going to release large amounts of urase and also some other toxic molecules that are then going to cause mucosal injury, leading to the ulceration. So we see the pain from those ulcers developing after eating, like right after they eat, and that could cause anorexia and vomiting, which we see more of with this gastric ulcer than we do with duodenal ulcers. Now, as far as treatment, it's going to be similar to duodenal ulcers. We can do long-term use of proton pump inhibitors, but it is a risk factor for developing gastric cancer after we get rid of the H. pylori infection. Continuing our talk on ulcers, let's talk about stress-related mucosal disease. This is an acute form of peptic ulcer that is related to severe illness or major trauma. The primary clinical manifestation is going to be bleeding, although that is uncommon, and we have 3 different types of ulcers that can develop. And usually we'll also have multiple sites of ulceration taking place. So first type is going to be ischemic ulcers, and this can happen within hours of trauma, burns, hemorrhage, or heart failure or sepsis. And this disrupts the mucosal barrier, causing the ulcer to take place. There's also curling ulcers, and these are going to develop as a result of a burn injury. And lastly, Cushing ulcers, and these develop as a result of brain injury or brain surgery. With this, we see a decreased mucosal blood flow and hypersecretion of acid because of overstimulation of the vagal nuclei, which results in damage of the mucosal barrier, and that causes erosions and essentially ulcerations. To treat this, we want to do prophylactic treatment regimens. So what about surgical treatment of an ulcer? Luckily, we've been able to remove the need for surgery for the most part thanks to acid suppression and eradication of H. pylori. but the most common indications are going to be recurrent or uncontrolled bleeding and perforation of the stomach or duodenum. And the point of doing surgery is to really reduce the stimuli for acid secretion, decrease the number of acid secreting cells in the stomach, and correct any complications as a result of the ulcer disease. So the surgeries that could be performed can be done to treat peptic ulcer disease, gastric carcinoma, or bariatric surgery for extreme obesity. And so that may develop into our post-gastrectomy syndromes. And some of the signs and symptoms that take place after that gastric resection will include, or may include rather, dumping syndrome. And this is when we have a rapid emptying of hypertonic or high solute chyme from the surgical residue within the stomach. And this could be due to a loss of that gastric capacity or a loss of being able to control the emptying from the stomach. When we remove the pylorus of the stomach, I'll point down here since we have our anatomical stomach here. So when we remove that pylorus, we start to lose the feedback from the duodenum. And so symptoms can include things like cramping pain, nausea, vomiting. We got osmotic diarrhea, hypotension, and weakness. Another thing that could develop is alkaline bile reflux gastritis. And this is going to take place when the stomach becomes inflamed. And that is because we get a reflux of, and this is what we're really seeing here, a reflux of that bile and the alkaline solution that comes from the pancreas. And it contains proteolytic enzymes that we're really going to use to break down the proteins or the fat or the carbs within the duodenum, but that then moves into the stomach area and starts to disrupt the mucosal barrier there. The symptoms that we see with this are nausea, vomiting, and sustained epigastric pain that is going to worsen after we eat, especially if that is going to be a fatty type of food. Another effect we might see is afferent loop obstruction, and this is when we have intermittent severe pain and epigastric fullness after we eat. If we have a volvulus take place, a hernia, adhesion, or stenosis of a duodenal stump on the proximal side of a gastrojejuostomy. And we could see this illustrated down over in this area where here is the small intestines. We have a obstruction taking place. So then we have that gastrojejuostomy here. And you could see that we've got some intestinal secretions that can accumulate, an increase in that intraluminal pressure in that afferent loop, and dilation of that afferent limb. So this could lead to things like vomiting to help relieve symptoms. Diarrhea is seen frequently, and an osmotic attraction of water into the gut. Another effect is diarrhea. This could be related to a rapid gastric emptying. Maybe there's dumping syndrome going on, and an osmotic attraction of the water into the gut. Weight loss is usually going to be caused by inadequate calorie intake, and anemia can occur if we have iron malabsorption because of the decreased acid production within the stomach. And we can also have some bone and mineral disorders develop because calcium isn't properly being absorbed, and we can increase our risk of fractures in that effect. The last big topic we'll talk about in this video is malabsorption syndromes. And this is when we have an interference with nutrient absorption in the small intestines. We use these two terms and sometimes they're used interchangeably, but maldigestion is really a failure of the chemical processes of digestion. It takes place in the intestinal lumen at that brush border of the intestinal mucosa, and is usually going to be caused by having deficiencies of enzymes that we need for digestion to take place, or maybe we have inadequate secretion of bile salts. The other term, malabsorption, refers to a failure of the intestinal mucosa to absorb digested nutrients. So we have some type of mucosal disruption maybe taking place due to a gastric or intestinal resection, a vascular disorder, or an intestinal disease taking place. So like I said, we typically are going to use maldigestion and malabsorption together, and this can sometimes make classification difficult. So let's first talk about pancreatic exocrine insufficiency. This is going to involve a decreased production of those pancreatic enzymes. You may remember these from A&P. We've got lipase, our pancreatic amylase, trypsin, chymotrypsin, and the one that's of particular effect is going to be lipase. And the reason we're not able to produce these properly is because maybe we have a damage or a loss of pancreatic tissue, and this has to happen quite significantly in order for us to see a significant or sufficient decrease of our enzyme levels to cause maldigestion to take place. And as that tissue is affected, we may also have an absence of pancreatic bicarbonate within the duodenum and the jejunum, and that could cause acidic pH, which worsens the maldigestion because our enzymes aren't able to work within an acidic pH. They need to be in more of that alkaline pH within the duodenum and jejunum. So what causes this all to take place? What is causing that damage or loss of pancreatic tissue? It could be someone who develops pancreatitis, pancreatic carcinoma, pancreatic resection, or even cystic fibrosis, because we know that there's going to be a buildup of mucus and a chronic inflammation and fibrosis or scarring of the pancreas. So we really know, because that lipase is really affected, that fat maldigestion is going to be the main problem. Although the issue is digesting all nutrients, this is going to be our biggest problem, though, is the fat digestion. And so that patient can then develop steatorrhea, in which we are going to find a large amount of fat in the stool. That will be our most common sign that we've got pancreatic exocrine insufficiency taking place. And then we'll also have a deficit of some of our fat-soluble vitamins, A, D, E, and K, which we are going to talk about in about 3 slides. But first, let's talk about lactase deficiency or lactose intolerance. This is when we have an inability to break down lactose into monosaccharides, and therefore it prevents lactose digestion and absorption. The reason is because we have a deficiency of a disaccharidase at the brush border of the small intestines, and this is due to a genetic defect in lactase in most instances. So when that person ingests lactose, that undigested lactose is going to remain within the intestines. It then gets fermented by bacteria and can cause gas, cramping, pain, flatulence, and osmotic diarrhea. So the best way that we can diagnose this is to take a lactose tolerance test, and treatment is really just to avoid milk products. Next up, we have bile salt deficiency, and we know from anatomy that we need conjugated bile salts to emulsify and absorb our fats. You could see in this image over here, we've got our lipid molecule and the bile acid is surrounding it, and this kind of puts the whole picture together here, where we are going to get that emulsification to take place. The bile salts start to aggregate with fatty acids and the monoglycerides to form these micelles, and they are going to make the fat molecules more soluble, and it allows it to move through the brush border that we see pictured here and into the intestinal villi. It's processed by the Golgi apparatus there, and then we can release it from the intestinal cell as a chylomicron, and that can then move into our lacteal. So this is why the bile salt is so important. And we know that they're going to be secreted from the liver. So when we have a deficiency of this, we cannot properly absorb our fats. And so we may have a deficiency because of liver disease and bile obstructions. Essentially, anything that's going to decrease our bile supply will decrease our micelle supply, which then won't let it absorb into the lacteal. And so our clinical manifestations are poor intestinal absorption of lipids, causing fatty stools, diarrhea, and loss of our fat-soluble vitamins, A, D, E, K. Like I said, we'll talk about these deficiencies in a moment. And then treatment would be oral bile salts. So now let's get to those deficiencies. If we have a deficiency in vitamin A, it could cause night blindness. A deficiency in vitamin D would decrease our calcium absorption, which can then lead to what we see here, bone pain, osteoporosis, and fractures. Decreased vitamin K could cause a prolonged prothrombin time, purpura, and petechiae. And a deficiency in vitamin E we're a little uncertain on those effects, but theories are that it may cause testicular atrophy and neurologic deficits in children.